Hello, and welcome to the 8th podcast on infection control issues. Today's issue on Let's Get It Straight is cleaning of vehicles and equipment. When we're talking about proper cleaning of our vehicles and equipment, we're talking about a basic element of protection, not only for those using the space, so protection of self as a care provider, protecting coworkers, and protecting the patients that we are serving in our communities. Now, the new healthcare law comes into this discussion as well. In 2009, it changed from hospital-associated infections to healthcare-associated infections. So why is that important? So let's begin by looking at the definition of healthcare-associated infection. This definition came into play in 2009. It was a broadened term. It used to be hospital-associated infection, but that changed, and a wider variety of entities that offer healthcare are now under this definition, and that includes EMS. A healthcare-associated infection is one that appears 2 days after admission, unrelated to that patient's admitting diagnosis. EMS comes under this. Ambulatory care, surgical centers, all now are under this definition, much broader than previously stated. So in 2009, the Center for Medicare and Medicaid Services sent out letters to every medical facility stating that the government would not be providing any reimbursement for healthcare associated infections. So patient is admitted for an MI and comes down with a urinary tract infection 2 days after admission. They would not get reimbursed for the care of that urinary tract infection. So what does this mean? Now that EMS has come under the definition of healthcare with regard to healthcare-associated infections, medical facilities are starting to look in your direction at your practices and how they might influence a patient infection that would be diagnosed 2 days after admission, unrelated to that admitting diagnosis. I took note of the fact that one of my peers was asking for input from members of the infection control community to supply information because they were looking at negative attitudes toward infection control, and that several in her administration wanted hard evidence done in ambulance services, fire departments, and their equipment. So they are starting to pay attention to your practices in the field. An example, a common scene. A call goes out to transport a patient from a long-term care facility to a medical facility. That patient has an indwelling urinary catheter. The catheter bag is usually placed where? Between the patient's legs on the stretcher, on the patient's abdomen. Well, that has an impact on the patient potentially developing a urinary tract infection, because if that bag is not below the level of the bladder, urine could back up and set that patient up for urinary tract infection that would be diagnosed 2 days after admission, and certainly not in line with their admitting diagnosis of a myocardial infarction. So what might this urinary tract infection cost? We always have to look at cost in today's world. So let's go down to the last one on the list. A urinary tract infection is over $1,000 per patient that the hospital would not get reimbursed for from Medicare or Medicaid. So there's a dollar amount assessed to infections now after numerous studies done in the healthcare environment. So where are we now? We're going to focus our cleaning on high-touch areas. You're hearing about this especially after transport of a patient suspect for or diagnosed with COVID-19. High-touch areas are areas that are in the immediate vicinity of the patient, things that were used to care for the patient or items that the patient was in contact with or that you were in contact with in caring for this patient. Now, the Society for Healthcare Epidemiology of America published back in 2012 that research demonstrates that daily cleaning of high-touch surfaces in the hospital environment and isolation rooms for patients with C. diff or MRSA significantly reduce the rate of pathogens on hands of healthcare personnel. The findings underscore the importance of environmental cleaning for reducing the spread of infections that may be difficult to treat, such as those that are multi-drug resistant. Definitions are always important. So let's look at the definition for disinfection, that it's a process of microbial inactivation that eliminates almost all vegetative pathogenic organisms, but it does not kill spores. So let's take a moment and look at the hierarchy of chemical agents. At the bottom of the slide, you will see lipid or medium-sized viruses. Listed is herpes, hepatitis B, HIV, and now we can add to this listing COVID-19. Being at the bottom here means that they are sensitive to the lowest level of disinfectant agents in the marketplace. You don't need, for example, to go up to Mycobacterium tuberculosis. The higher up the chain you go, the more expensive the product. And it does way more than what we need to achieve on each individual patient transport. So we need to pay attention to the type of virus that we are looking to kill and where it is on the hierarchy of chemical agents. And the ones that we are focusing on, for the most part, are the easiest to kill by disinfection. So what do the CDC guidelines say about cleaning? In particular, high-touch surface cleaning. It says, perform low-level disinfection for non-critical patient care services. Low-level would be what we were just talking about, the ones at the bottom of the chemical agent chart. For example, stretcher railings, equipment used to care for the patient, a blood pressure cuff, for example, or anything that would touch intact skin. Now, I mentioned that the low-level disinfectant agents do not kill spores. Clostridium difficile and norovirus both require a chlorine-based cleaning solution to kill these organisms. Please take special note of that when making selections based on the diagnosis of the patient that you have just transported. Selection of our cleaning agents needs to be a process that we consider meeting need and purpose. Does what we are going to purchase meet that criteria, need and person? Certainly we want something that is easy to use. What about safety procedures? Is personal protective equipment needed to utilize that cleaning agent? Is it suitable for the surfaces that you will be cleaning? Does it save time? And we want to be sure to check the safety data sheet. Cleaning routines, making sure we are using the proper products. Now, it's been my experience, and I have worked all across the country with many different departments, and for the most part, I find that most departments have way too many cleaning supplies. That can lead to errors in using a product properly. If you have so many different things, and if they have to be mixed or they have to be dated for disposal, more margin for error, the more products you have. So limit your number. And of course, OSHA requires that you publish a cleaning schedule and that you're going to document that your cleaning routines were followed. So that is clearly a requirement in the OSHA bloodborne pathogen regulation, and we find the importance of cleaning addressed as well with regard to COVID-19. Checking the safety data sheet is important before we purchase. As I mentioned, a lot of times we see the improper mixing of a product, and therefore it isn't going to be effective, or that expiration times were not checked. And people were unaware that personal protective equipment was required to use that cleaning agent. The Centers for Disease Control is very prone to suggest premixed products be considered. They approve of them greatly, let's just put it that way, because it can avoid things not being thrown out by the date they should have or not being mixed properly. The work is done for you. They've also stated that you only need a 1-minute contact time. Now, there are many different pre-mixed products in the marketplace, so you should be taking a look at these, and I think you want to really bring in here more than one person making the decision on what to purchase. You don't need a large committee, but you certainly want more than one person to have input, maybe 3. Multiple scientific papers demonstrated significant reduction in organisms with contact times of only 30 to 60 seconds. And at the bottom of the slide, I have given you the reference for this information. Now, compliance monitoring is an OSHA-required component of your exposure control plan, not just for bloodborne pathogens, but also your plan for COVID-19. Now, this was published a few years back in the Journal of Pre-Hospital Emergency Care. It was an observational study performed by Dr. Brian Bledsoe and his associates. They did actual observation of response for 423 EMS crews. 56.9% were wearing gloves appropriately. 27.8% performed hand washing. 27.8%. That's abysmal. And 31.6% disinfected reusable equipment. Now, I certainly hope that we have, as care providers, improved upon this since this study was conducted. But it certainly gives us pause to look at this data. So we now are seeing marketing stressing the importance, from their point of view, of using automated systems. What is important to realize is that you still must clean first. You cannot achieve disinfection without first cleaning. And sometimes that information isn't shared. So the guru of cleaning, disinfection, and sterilization in the United States is Dr. William Rutala. He is at the University of North Carolina, Chapel Hill. And I wanted to share with you his quote from an interview in Healthcare Hygiene magazine from January of 2020. He stated, "The rationale for rigorous manual cleaning and disinfection before the use of UV technology, for example, is that organic material, if it's present, can interfere with disinfection technologies. Bottom line, thus surfaces must be cleaned prior to the use of automated disinfection technology." So this begs the question, if you still have to clean first, what are you gaining by using automated technology? And this is a question that needs to be discussed in your departments. An answer often is from marketing that their equipment will get to areas that you can't get to clean. So I think the follow-up question is, if it's an area you can't get to clean, how would that pose a risk to you or your patient? Food for thought. Items to consider when purchasing. We need to do homework before we purchase. Remember this always. Dose needed to infect and mode of entry are key to assessing risk. Reducing the number of microorganisms that can be inactivated through meticulous cleaning increases the margin of safety when the germicide is used according to the labeling and shortens the exposure time required to kill the entire microbial load. Dose is key to risk, and it must be partnered with mode of entry to infect. So OSHA is enforcing the CDC guidelines, and they are doing that using the General Duty Clause from the OSH Act of 1970. A lot of people are missing this key point. that OSHA is enforcing CDC guidelines. Now, the General Duty Clause from the OSH Act has Part A and Part B under Section 5 duties. Part A refers to the responsibility of the employer, but Part B addresses the responsibility of each employee, that each employee must comply with the OSHA rules, regulations, and orders issued pursuant to this act, which are applicable to his own actions and conduct. Well, you can see this was 1970. It only addresses his. We will add her as well. So compliance monitoring and documentation that your cleaning routines are being followed is liability reduction. Remember, the hospitals are starting to look at the way you practice. If they want to say, well, we don't think this infection is our fault, we think it's your fault because we know you are not properly cleaning, and you can produce compliance monitors that show that your cleaning routines are being followed, that is going to be extremely helpful in reducing risk and potential liability. So our bottom line, nothing replaces routine initial cleaning. And, you know, everybody's looking for the quick fix. We know that. But some things can't be eliminated or set aside, and that's routine initial cleaning. I hope I've given you some food for thought. It's really important, especially during the time of a pandemic, that we don't find ourselves doing impulse buying without first doing just a little bit of homework that doesn't take very long to do before we purchase. And having some sort of a committee, small number group, aiding in making that decision will also be helpful. We want to focus on, does the product meet need and purpose? And we also want to look at cost. So I hope this has been a good refresher for you. And I also hope you will join me again next time for the next installment episode of Let's Get It Straight. Again, thank you so much for your time and attention. If you have additional questions or would like additional information, please feel free to contact me. I've given you my office number and my email address. Take care and stay safe.